Our last speaker of the session and of the symposium is Louise Oaklander, a close collaborator and a friend from Mass General Hospital, where she directs the nerve unit. Louise received her MD and PhD from Einstein and then did her medical residency and neurology residency at the University of New Jersey. She then finally went on and did her fellowship at Hopkins, where she overlapped with Dr. Rowe, apparently. Dr. Oaklander has spent her career studying a relatively unknown part of the human nervous system, which is the small fiber nervous system, and she has done a fabulous job of putting together some of her basic research with clinical findings, including fibromyalgia, and we'll see what she has to say about ME/CFS today. Louise.
Thank you very much for the introduction. I know I'm the last speaker, so as you'll see in a minute, I've actually put my conclusion slide as the second slide so that you can leave after that. But before I do that, I just want to acknowledge one additional part of my training, which isn't you wouldn't necessarily know about, but that's the many years that I spent learning from Walter Koroshetz and Ann Young at Mass General. And I think what you'll see is I'm going to echo some of the things that he opened the meeting with. So he and I are going to be bookends in a way. But then I realized that's not actually just by chance, because he helped to give me the approach that I have and that I'd like to share with you in just a few minutes. And my approach is that it's very helpful to patients if they end up with a diagnosis. And so I'm going to focus really on pathology. We heard about pathophysiology in the previous talk and also from Dr. Systrom. I agree completely with the things that are said. I'm going to talk now really about cell biology and a cell that I think contributes to the problems that some of these patients have. And again, that's because as a neurologist, I'm trained to localize what part of the nervous system is involved and then to look at the etiology. So Walter, I hope you'll stay to the end and maybe you could let me know. Okay, so to give you my conclusions in advance, I'm going to tell you that small fiber neuropathy or polyneuropathy is a cause in some patients, not all, of multi-symptom illnesses, that in the majority of patients, even in advanced countries and settings, it remains undiagnosed. Skin biopsy is the test that's endorsed by the American and European Academies of Neurology for objective confirmation. I'll show you some of our data in fibromyalgia. I'm then going to move on to etiology, the second part. If you have a cellular diagnosis, you need to think about what the underlying medical cause could be in that person. It's different in different people. And the reason to do that is because if you can come down to localization and etiology, then you have an actual diagnosis, not just a label or a syndrome. And that then puts you on the pathway towards more effective and potentially disease-modifying treatments. And then I'll end by telling you a little bit about our research. But before I do that, I'd like to mention the reason to do all this is because these small fibers, actually their biology is such that they continue to grow throughout life. We've heard a lot about chronic disease being chronic, but in fact here, if you can figure out what's going on and improve it, there are substantial chances for improvement. I'm talking again about nerves that connect the brain and the spinal cord to the outside world. Our peripheral nerves are mixed. They have different kinds of axons in them. And what I'll be speaking about are these small unmyelinated C fibers and the very thinly myelinated A delta fibers, and then the autonomic axons, the postganglionics, particularly the sympathetics, are mixed in. Polyneuropathy means that all or most of the nerves in the body are affected. We neurologists, and I'm sure Walter would agree, we just weren't taught a lot about these in our training. For number one, because they're hard to see, you need special techniques. But number two, because when the patients get sick with this, they just develop all sorts of different symptoms. They get sent to different specialists, each of whom make a different diagnosis, And a lot of times the underlying neuropathy doesn't get diagnosed. And by the way, POTS, more than 50% of POTS was shown to be this kind of neurogenic, small fiber mediated. So I'm going to give you a brief clinical overview and then move into the research. Chronic pain is one of the major symptoms of small fiber because, again, these are our pain neurons. They also mediate itch. That's been underappreciated, but it's a common symptom in many patients. In about 3/4 of patients, the symptoms will develop in the feet first. And this shows you what neurologists call erythromelalgia, but which we were just hearing about from Dr. Rowe, where you have microvascular changes and visible color changes in addition to the pain. The few patients at the bottom on the face may have attack directed at their cell ganglia, the cell bodies in the ganglia, rather than the axons. I don't want to belabor this point, which we've heard about wonderfully from our previous speakers, but I will just bring your attention to 2 slides that I think speak to the cellular mechanisms of some of what we've spoken about. I don't know if you can appreciate this immunohistochemistry from Alan Pestrong's lab, which actually looks at the innervation of the neurovascular bundles that go to the muscle cells. And what it shows you, the merged images here, show you that in the normal patient whose panels are at the top, there are lots of axons. When we look at the blood vessel in cross-section, the yellow squiggles are the innervation. When we looked at a patient with they look at a patient with small fiber polyneuropathy, you can see that the blood vessel has lost most of its innervation and it's gaping open, as we just heard. And again, we heard already about some of the consequences of this and the fact that in these type of patients that David Systrom is looking at, about 30% of them have skin biopsies diagnostic of small fiber neuropathy. I'd also like to mention the arteriovenous shunts, because that, I think, is a contributor as well. The AV shunts permit the blood to bypass the capillary beds and jump directly from the arterioles to the venules. They're normally closed for obvious reasons. But very nice work from the lab of Frank Rice in Albany, studying patients with fibromyalgia, 18 and 14 controls, showed with immunohistochemistry that there's loss of innervation and consequently an opening, gaping open of these arteriovenous shunts, so the blood may be circulating, but it may not be making it directly to the capillary beds. The gut is densely innervated by small fibers, as shown in the immunohistochemistry from my lab at the top. GI symptoms are also common, and worst case scenario, one of them is shown at the bottom. Some of these patients have such severe problems that they become cachectic and malnourished. And in the teenage girls, it's very often attributed to anorexia nervosa. I also won't belabor the point that this has consequences on the brain. So because the symptoms are multiple and kind of nonspecific, we really recommend objective confirmation. And again, it's these skin biopsies that are endorsed by neurologists. If you look on our website, neuropathycommons.org, there's information about how to get them shipped to our lab, how to do them if you're a provider. I'll make the point, though, that not all skin biopsy labs are created equal, and you need to look and see where the lab that's interpreting your biopsy actually is getting their normative data from. And so I'm showing you, and this is the work of largely of Max Klein and many others in our lab, this is more than 400 skin biopsies from normal individuals of all ages. And I show you this to show you that normal young people, here I think this is people under the age of 25 in red, normally have up to 4 times as many of these nerve endings as normal older people. So if you just apply a single diagnostic threshold, you're going to have false positives from the old people, and you're going to have a ton of false negatives from the young people. We get sent skin biopsies all the time interpreted as normal from other labs. And insofar as I know, please correct me if I'm wrong, NGH is the only lab in the world with actual normative data from children. So please think about the lab that's interpreting your biopsies. Beautiful immunohistochemistry can be done. These skin biopsies are very useful for research. I'd like to, and again, I'm not sure how well this comes out, but this shows you staining of different components, and I'd like to particularly draw your attention to the innervation, the dense green innervation of the arteriovenous in blue anastomosis. And again, this is from the lab of my co-author, Maria Nolano, who I consider to be an artist who paints with immunohistochemistry. Maria and I are just publishing a review paper together in JAMA Neurology, so that's something you might want to look for later this year. And again, you can see that these small fibers have many, many different roles in the skin. The panels on the edge are from a healthy 10-year-old boy. The other panels are from a similar age boy with Fabry as the cause of his neuropathy. We completely endorse the use of physiology tests. We do them as well in our lab. The conventional Mayo composite autonomic function testing. AFT has advantages. It's totally non-invasive. It can be repeated. It's used more often as an outcome measure for trials. But unlike the biopsies that can be taken anywhere in the world and mailed to a lab, the patient has to show up to the AFT lab, has to prepare in advance, hold medications, and sometimes the results, as we heard, are not specific. So I think they're complementary. I'm going to turn now to some of our research. Max and I, in 2013, published this paper in the journal Pediatrics, which I think is one of the early papers. It's certainly the first large case series looking at this problem in children's and teens. And this was a group of 41 patients with the onset of chronic widespread pain before age 21. We didn't rigorously screen them for such, but most of them were labeled as, would have been labeled as juvenile fibromyalgia. Many of them would fall into the category of patients we're talking about here. And although pain was the inclusion criteria for this study, almost all of them had other non-pain symptoms. In studying these young people, to look for cause, it was by studying young people that it really emerged to us that here the signal, there was less noise in kids, so the signal came out more clearly. And the signal that came out to us was inflammation and perhaps autoimmunity, both because of personal and family histories, but I think more directly because the vast majority of these patients had standard serologic blood tests that are considered soft signs of inflammation, systemic inflammation. We were able to find objective evidence of small fiber neuropathy in 59% among that young series, and combining this information that a lot of them had neuropathy and that in them perhaps the cause was autoimmune, we were able to show a 80% response rate to immunotherapies in the very small group. I should emphasize we did not give this treatment to everybody, nor would I encourage it to, and it would be a mistake to think that this is a universal treatment for small fiber neuropathy, because it is not. That was a retrospective look back for a more rigorous study. We next focused on fibromyalgia because of the ACR criteria permitted us to identify a homogeneous group for research. These are patients that had both the clinical diagnosis and they met the full rigorous ACR research diagnosis. We studied the 4 pillars of clinical medicine, which are symptoms, signs, pathology, and pathophysiology. All of these outcomes were consistent with small fiber neuropathy, and most notably, 41% among that group versus only 1 patient in the control group who later, actually 3 weeks later, was diagnosed to have MEN2, which is a cancer that's associated with small fiber neuropathy. So highly statistically significant overrepresentation of small fiber neuropathy. We're just getting ready to present at the American Academy of Neurology meetings a follow-up study in teenagers with juvenile fibromyalgia. And we're going to report essentially the same thing. Our paper was very difficult to get published because of the controversy surrounding fibromyalgia and previous studies that needed to be retracted from high-profile journals. But what ended up happening is that virtually every single study published since is all singing the same song, that about 40% of fibromyalgia patients have some type of objective evidence consistent with small fiber neuropathy. And I draw your attention to this review article in Scientific American Mind that discussed this. I have not studied CFS ME, but I just want to briefly mention our work in Gulf War illness, which suggests evidence that small fiber neuropathy is quite significantly represented not only in fibromyalgia, but in other multi-symptom illnesses. This work, we're very grateful to our funding from the Department of Defense, and this is work we're doing in collaboration with the East Orange VA. I realize this is data from 42 Gulf War vets and 51 screened demographically matched controls, but in fact, this doesn't even include the data from the East Orange VA, so we're probably pushing towards 100. Time to move away from abstracts and publish in full, which we'll be doing later this year. But we're finding the same thing, that about 40% of the Gulf War symptomatic vets have objective evidence. Very interestingly, the results were identical in the non-symptomatic Gulf War vets. So this suggests that small fiber neuropathy is highly prevalent in this group, but that it doesn't go on to cause Gulf War symptoms in all of them. So I think it's part of the picture, but certainly not the whole picture. So moving on to part B is, if you make that diagnosis of small fiber, your immediate next step is to identify the medical cause. We published on this in 2016, evaluating the tests to do. We've created this form. The residents use it as a cheat sheet. It's available for your use on our website. Don't hesitate to use it. Again, diabetes is overall the most common cause of small fiber neuropathy. There are a number of other medical conditions. Most of these patients turn out to be what we call the initially idiopathic. But if you do all the blood tests, you do find a cause in about half of them. Again, these are the 3 tests, 2 that I published and 1 from a study in the Netherlands of 921 patients. And all these studies are highlighting the high prevalence of markers of dysimmunity. The reason for this, I believe, is that the small fibers are intimate, to use a word that we know, with the immune system. And the reason is because that's part of their job. There are protective nerve fibers, and to do that, they migrate out of the CNS into the periphery. They have fenestrated capillaries, and they crosstalk with the immune system. That makes them vulnerable to threats, both infectious threats and autoimmune markers that we've heard about, cytokines, inflammatory mediators, paraneoplastic syndromes. So a trickle of cases of what seems to be small fiber restricted autoimmunity was published, some of which are ours. And then I believe that the largest is our 55-case series from 2018, among whom 3/4 did not have the systemic diagnoses. Sjogren's is, without question, the most common, and I'll refer you to our little New England Journal piece from 2018. This is another 2018 publication, retrospective, but first large study on the efficacy of pooled immunoglobulins. The fact that IVIG is helpful in some is additional indirect evidence of B-cell and autoantibody mediation. In this study, we use the results of autonomic function testing as the co-primary outcome to give an objective marker in addition to pain, very important to the patients, so that's why we had those 2 outcomes. Both of them improved statistically significantly. We need more direct evidence than retrospective studies, prospective studies, treatment studies, and that's beginning in our lab and elsewhere. The best study I know of is this passive transfer study from the lab of Yuki in Singapore, where they took serum from patients who had what we call apparently autoimmune small fiber neuropathy. We say apparently because, again, it's really not proven. This is an hypothesis that's being explored. They injected mice with sera from these 3 Chinese patients who they thought had this from a ton, like 25 or 30 normal controls and patients, I believe, with CIDP. And they showed that the serum from the Chinese patients who they thought had the neuropathy produced behavioral changes in the mice, and then the expected pathology in the dorsal root ganglion and in the spinal cord. We're building metrics in my lab, both the SSS, the Small Fiber Symptom Survey, and we'll soon be publishing the Magnet, the Mass General Neuropathy Exam Tool. We, like others, other labs, routinely collect serum, DNA, plasma, and these kind of standardized data that Dr. Shunts has encouraged. The goal, again, is to be able for people to collaborate around the world and to be able to pool our data in a way that's comparative. For the many excellent basic scientists in the audience, I would encourage you to think about phenotyping your patients with these standardized metrics, which I think will facilitate your basic studies. I'm going to end just by a hand-waving calculation, the best we can do for now, about what the prevalence of small fiber might be. I know of only one published epidemiologic study from the Netherlands that would predict that there may be 4 million cases. But as those relied on only diagnosed and confirmed cases, and it's estimated that 90% are in fact undiagnosed, perhaps 40 million worldwide might be a more accurate figure. But on the other hand, just feeding in the data from the fibromyalgia studies now moves us up towards more like 400 million cases. So we don't have an accurate estimate at this point. We do need a better case definition than the epidemiologic studies can be done. But certainly the data suggests that this is not a rare condition in either adults or children. So I'm going to go back to the stuff that I told you at the beginning, and what I've tried to demonstrate, I hope effectively, is that small fiber polyneuropathy has many symptoms, not just the painful feet that physicians learn about in their training, that precision diagnosis, both a anatomical, pathological, physiologic diagnosis, and then the etiology offers patients a path towards better treatment, and by the way, parenthetically, towards insurance reimbursement for that treatment, which is a very important consideration these days, that skin biopsy is right now the best accepted objective diagnostic tests. Again, please go right to the blood tests, figure out what the cause is in your patients, that this does affect children. We need more pediatricians to come into the dialogue and let their pediatric colleagues know about this, and that in the kids and the teens who don't have diabetes, most of them don't have HIV, don't have chemotherapy, in them, you really have to think very seriously about inflammatory causes. I've not had time to talk about genetic neuropathies, which is another major clinical and research interest. I lectured last year at Radcliffe in a longer format. If you're interested in hearing about the genetic cases, you can find that lecture on YouTube. Again, the data so far from our lab and elsewhere suggests that we're on track to discover the correlate of Guillain-Barré and CIDP, which are autoimmune neuropathies just directed at a different fiber type. The final data are not there, but that's certainly the way things are heading. And again, there's very early evidence. The reason why this discovery, I think, is important for patients is that it kind of gives a bit of a roadmap toward treatment. And again, the estimates from other studies are that about 40% of patients in these research cohorts do have evidence of small fiber neuropathy. So again, we're very grateful to our funders, to our internal collaborators in the lab, and to our external collaborators. I hope very much that this meeting will give me the opportunity to make new collaborations and give me the opportunity to help you advance your work as well. Thanks very much to everybody who stuck it out. Thank you so much.
For questions, Louise. So, Dr. Oaklander has left us some time for questions.
Yes, my question is, aside from patients with painful feet or widespread pain, I know we're here about CFS and talked about POTS. Are there criteria for which patients should undergo skin biopsy, or do you have some guidelines for other conditions when it's appropriate, what the indication is?
That's an excellent question. And as a clinician, if I know that 40% of a certain symptom is caused by a particular disease, golly, I'd really be thinking about that test when I see patients with that symptom. Now again, that's not to say that everybody with chronic fatigue or fibromyalgia, the data show clearly that they don't have it. But golly, yeah, very good question. Wish I knew the answer, but very good question.
Very interesting presentation, thank you. I didn't get to read the slide fast enough, but on the Gulf War slide where you had essentially the same level of positive biopsies in asymptomatic Gulf War vets, there also was a column for healthy volunteer, healthy controls, and it looked like the positive rate in that was around 15%. I couldn't tell exactly. And so is that true, and in which case, what's the prevailing background rate, and how much of what is observed in that particular study might be just a variant?
Yeah, I don't want to actually get into a detailed discussion of our Gulf War data. I'd like to keep the focus on the topic here, but you're right, that's a high rate. And I think that the reason is because we used a demographically matched group. And when you look at that cohort, older middle-aged men, there's a not significant prevalence of conditions that can cause neuropathy. So yes, you're correct.
Okay.
So this is about a real patient who's too ill to be here today, who's been labeled by your institution as having a functional or somatic disorder when he's been previously diagnosed with autoimmunity and polyneuropathy. How can he get help and get into the correct neurological area in your institution, please? He's being treated like a psychiatric patient right now.
Yeah, I don't have a good answer for you, and I think because all of us in the audience know that this happens routinely. The skin biopsy, although not perfect, there are false positives, false negatives. I don't want to leave you with the mistaken impression that it's perfect, but it's very convincing because it's pathology. And so what I suggest to my own patients is that they really try to get that peripheral neuropathy diagnosis on their chart into their doctor's note and try to minimize some of the red flags. This is, maybe the art of medicine, and maybe not everybody would agree, but you got to get medical care. And I think it's really important not to scare doctors away. And it's understandable that people develop depression, anxiety, deconditioning. I mean, I get it. But it doesn't always help patients to get the medical care they need.
Thank you.
And part B, of course, is medical education. So there's something called the Valley of Death that this is in. It takes 17 years, they say, after you publish the papers, for the general physicians to become aware of it. It's really unfortunate. And then the insurance companies are even worse because, they have their own policies about they will and will not pay for, and just because something's published in the literature, yeah, okay. Next question.
Thank you.
I think this will have to be the last question.
Okay, thanks, Olli Polo, Finland. Are you aware of any data how sensitive the peripheral nerve fibers are for hypoxia, for tissue hypoxia?
They're very sensitive because these are the longest cells in the body. The neuronal cell bodies are in the dorsal root ganglia next to your spinal cord. Those axons are going all the way down. They have the highest surface to volume of any cell that I know of in the body. I call them the canaries in the coal mine. And so that's why many neuropathies, including diabetes, and even they're finding, in ALS that there's small fiber degeneration. So they are the most sensitive nerve cell to hypoxia. Thank you very much.
Thank you, Dr. Oaklander.